Welcome, everyone. It's 8:31 Central Time. I thought we would go ahead and get started. Yeah, so welcome to the 2023 Wastewater Disease Surveillance Summit. It is so wonderful to have all of you here, whether you're joining in person in Chicago or online on Zoom. It's great to meet a lot of you in person for the first time. So I'm Mehrotra, Director of the Wastewater Surveillance Program at WEF. You get probably a lot of emails from me, so thank you for your patience with that. But we have a really fun program planned today. You might have gotten the sense looking at the program that our focus in the morning is especially going to be on implementation challenges. We're going to talk a lot about challenges, hurdles, barriers. And then in the afternoon, we're going to get into some hot topics and some deep dive into ethics, which I think is a topic that's top of mind for a lot of us. I just wanted to extend a sincere appreciation to the CDC for funding this event and making it possible. Very happy that the government is still in session. Woohoo! So I just wanted to go through a few housekeeping items and then we will jump into the program. It has a QR code on the front that will take you to this digital program. This will be the home screen that you'll see on the digital program, which has a summary of the day, some safety information, lunch options, all the speaker bios, and something a little bit more about WEF vision and core values, and some small group discussion topics. I'm going to get into that in a minute. This is the QR code. There's also a bit.ly, WDSS 2023. Bit.ly is case sensitive, so all of those should be capitalized. So definitely check out the program. Please do review the safety information in that program, but the key thing to remember is you can dial 55 from any house phone, or please use 911 from your cell in case of an emergency. There is Wi-Fi for everybody here if you would like access. It's actually Hilton Chicago Meeting is the name of the Wi-Fi. Hilton Chicago Meeting, and the password is WEF WDSS. In person, when we do Q&A, we would really like us to use mics. That we're going to walk around with a wireless microphone, because that way folks online can hear your questions. And so we'll make sure to catch up to you if you have a question. Definitely ask questions. We want this to be interactive and a good learning experience for everybody. If you're online, anytime you have a question, please use the Q&A feature. I know it's sometimes hard to remember to use the Q&A. We will definitely monitor the chat as well, and we'll make sure that your questions get asked. All right. This afternoon, we're running a little experiment with all these people. We're going to attempt to do breakout rooms, both in person and online. So for all of you sitting here in Chicago right now, I have a favor to ask you. During the break, which starts at 10:15, or during lunch, walk out through those doors. You'll see a series of tables with some pieces of paper on them. Those are your sign-up sheets for the breakout discussions after lunch, because we kind of want to keep it to no more than 10 people per table. That's really the number of chairs we have around each table, and plus then everybody can participate in the discussion. If you need a reminder of what the breakout topics are, they're out on the sign-up sheets, but also they're on the digital agenda. If you are online, it's an even bigger experiment. We're going to really try to make these breakout sessions work online. You guys will have the same 17 topics, so 17 different breakout rooms. We will open up the breakout rooms 1 through 17 right after lunch, and you can choose online which one you want to go to first. You will all, in person and online, have a chance to rotate through 2 small group discussions, so 2 different topics. So just keep that in mind. So pick the 2 that are of most interest to you. Any questions so far on anything? No? Okay. I wanted to extend a huge thank you to our program committee. I don't know, some of you might not be aware that we were originally going to do the summit back in June, and then we moved it to October 1st, not really thinking that a government shutdown would ever complicate things, right? So these folks hung in there with us through the whole thing. So Brian Brock, Lee Heberlein, Ryan Jepson, Reva Katz, Amy Kirby, Rasha Malbared, Frank Martz, Aaron Morin, Naoko Munakata, Allison Wheeler, and Sarah Wright. Thank you all so much for everything that you did to make this happen. So can we give them a round of applause? All right, before I turn it over to John Person, who will be welcoming you officially from the CDC, I thought you all might be interested in seeing who we all are. This is a little pie chart of where we all come from. And I've made the little caveat in the bottom left-hand corner that these are data for in-person registrations only. We have about 190 in-person registrations and 200 virtual. So the biggest pie piece are folks from health departments. I think these are mostly non-laboratory folks, so EPIs, biostatisticians, and the like. The second biggest pie, kind of tied with the second and third, maybe even the fourth, are all kind of tied. So educational institutions, utilities, and laboratories. So those can be public health or environmental labs. And then we have some smaller slices, consulting, contracting, and planning. Federal government, I think we have one in-person federal government today, which is wonderful. A nonprofit and other. Actually, I'm just curious if you all don't mind. If you're in the first pie piece, the health departments, can you raise your hand? Awesome. Okay, what about the educational institutions? Okay. Utility folks, sprinkled throughout. Laboratory folks, also sprinkled. Consulting, contracting, planning, you know who you are. We've got one brave soul over there. Excellent. Federal government, where are you, Sally? Yahoo! Thank you, Sally. Nonprofits. All right. And then other, which, okay, wonderful. You count, even though you're in the other category. Okay, so I'm now going to turn it over to John Person. First, I will read his bio. Mr. Person is currently the state, territorial, local, and tribal support lead for the CDC's National Wastewater Surveillance System, or NEWS. He has been involved with NEWS since late 2020, where he has helped develop many aspects of the program, including establishing the STLT support team. Previously, Mr. Person worked for the Waterborne Disease Prevention Branch and the Louisiana Department of Health as an epidemiologist. He earned his MPH from the Louisiana State University School of Public Health. So John is going to take it away.
Hello, everyone, and welcome to the 2023 Wastewater Disease Surveillance Summit. I would like to start off by thanking you all so much for being here. I would love to be there to see all of your smiling faces, shake all of your hands, or bump all of your elbows, and get a chance to speak with every single one of you. If you are seeing this recording, it's likely because there has been a tiny inconvenience in the fact that the government might have shut down. But that shouldn't stop all of you from getting to have all of the fun. Speaking of fun, when I first heard of wastewater surveillance, I knew this was something that I wanted to be a part of, as I'm sure is the same as all of you. Since then, we have been rewarded with triumphs as well as challenges. We have gotten to meet and work with some of the most brilliant and innovative people in public health. We've gotten to see the many different examples of innovation, some of which you will get to hear about today. We have encountered hurdles and come up with solutions, and we still haven't been stopped. Together, we have answered some of the tough questions we haven't even needed to answer in the past, particularly navigating the ethical components of wastewater surveillance. We've come up with interesting topics, hot topics, if you will, of discussion to further the field of wastewater surveillance, new applications. And we've developed a community that is collaborative, innovative, and frankly, amazing to be a part of. So it's hard not to be proud to be part of this community. So thank you, and thank you so much for making this such a wonderful field to work in. I'd also like to take a moment to give a big thank you to our hosts at WEF. Thank you for putting this together. Thank you for hosting. Thank you for doing all that you do to support wastewater surveillance across the country. We couldn't do this without you, and we're very grateful. Speaking of people we couldn't do this without is all of you. I'm referring to everyone in the room today. Wastewater surveillance is supported by a wide range of professionals, from federal to state to local, territorial, tribal, utilities, universities, healthcare, corrections. We have different disciplines: laboratory, epidemiology, data science, engineers, wastewater operators, and many more I couldn't possibly name in time. We have been known by many different names, from poop sleuths to dookie detectives to wastewater investigators. And it's wonderful to have you all gathered here today to share what you've learned about wastewater surveillance. It inspires me to imagine the things that we'll accomplish together moving forward. I've gotten the opportunity to watch wastewater surveillance expand rapidly over the past 3 years, especially geographically across the entire United States. There isn't a state where wastewater surveillance doesn't exist. I think now we are at our sewer shed moment, so to speak. We are changing the direction of which our pipes are flowing. Well, not literally. New testing targets are being introduced, new applications of wastewater data are being invented, and we're working together to make sure there's a lasting impact on public health. So finally, I'd like to say again, welcome to the 2023 Wastewater Disease Surveillance Summit. There is an excellent program ahead of you. We're starting off with some implementation case studies. There's going to be a panel on hurdles and solutions. After lunch, there will be breakout sessions to continue discussing hurdles. We're going to have some presentations on ethical considerations in wastewater surveillance programs. And lastly, and one that I'm particularly excited about, is hot topics in wastewater surveillance. It's going to be a great day. I encourage you all to meet someone new, share some ideas, learn from each other, give everyone a pat on the back for me, and have an overall wonderful time. We at the news team at the CDC are sad we couldn't participate, but we're so glad it's carrying on without us. We'll miss all of you, and thank you for everything. Take care.
Okay, so John kindly recorded that on Friday, thinking there was going to be an actual government shutdown. They truly are not here in person, the news team. However, they are on Zoom. And so you all in your email invitation or details for today got the Zoom link. You are more than welcome to, well, actually probably the best way for it to work would be if you all have questions for Amy or John or the rest of the news team on Zoom, just ask them in person and they'll be able to unmute and answer. Does that sound good? So again, I know that they're really disappointed that they're not able to be here, but at least they can officially participate on Zoom. We'll take it. All right, so you all know that no two wastewater surveillance programs are alike, right? And no two wastewater surveillance programs started out the same way. So in our first session, we're going to hear 4 very different case studies at different scales to kind of, talk about what all the different challenges that folks have faced in different kind of startup modes for wastewater surveillance programs. So we're going to start out very local, talking about Chicago, and we're going to hear from Kaylyn Patterson at Metropolitan Water Reclamation District. And I think you'll notice too that we've been very conscious throughout this program to make sure that we're hearing from all the different stakeholder groups that participate in these programs: utilities, laboratories, health departments, academics. Then we're going to go a little bit north and west to Anchorage and hear from Reva Katz about the city of Anchorage's program. Now, you all know, you're probably by now very familiar with the ELC funding program. A lot of the jurisdictions in the room are funded through the ELC program for news activities. Well, the city of Anchorage is not an ELC eligible jurisdiction. So it'll be interesting to hear from Reva about how she's been able to stand up a program without sort of that funding infrastructure. And then we're going to come back this direction a little bit and hear from Angellica Stanley about the state of Minnesota. And then we're going to go across the ocean and we're going to hear about the Netherlands from Gertjan Medema, who will be joining us virtually. So without further ado, I'm going to introduce Kaylyn. And then I'll turn it over to you. Actually, let's see. And Reva, would you like to come up too? And Kaylyn, you guys want to come on? Go ahead and come on up. We will have plenty of time for a Q&A. As I mentioned, we're going to walk around with the wireless mic. So if you have a question, raise your hand after we. I think we'll hold until the end when we can have like a group Q&A. Yeah, and I just want to say thank you to Kaylyn for coordinating the tour tomorrow morning at the Egan Water Reclamation Plant. Who's able to go on that tour tomorrow? A few hands. Wonderful. Okay, fabulous. All right, Ms. Patterson is an associate environmental microbiologist at the Metropolitan Water Reclamation District of Greater Chicago, or MWRD. She is primarily responsible for supervising MWRD's bacterial analysis for water and biosolid monitoring programs. She also ensures the microbiology lab continues to maintain and comply with the drinking water certification standards set by the Illinois Department of Public Health. Ms. Patterson started MWRD's sewage surveillance project coordination in March 2020, and which seems like a lifetime ago now, right? And has continued leading MWRD's surveillance participation by establishing partnerships with universities, public health agencies, and laboratories.
Thank you, Anna. Thanks, everybody. I'm glad that you all could come and participate in our sewage surveillance program by being here in person. Hopefully, those of you online can come and visit Chicago at some other point in time. So just a brief overview of what I'm going to talk about today is a little bit of our participation timeline. As Anna mentioned, we started in March 2020. I'll go over a little bit of our water reclamation plants in our jurisdiction, our sample process, and how we attempted to kind of minimize the burden of sewage surveillance and bringing it to our utility. And then probably the most important thing for our program to be successful is communication. And so I'll discuss that at the end. So here's a timeline of our program and our participation. So in 2020, Allie Boehm and Krista Wigington out at Stanford University reached out to us and asked us if we wanted to participate in their program. They had received some funding from the National Science Foundation. They were looking for a large wastewater treatment plant to participate. And so we actually began sampling with them in March 2020. UIC, the University of Illinois Chicago, Rachel Pretsky's team with the DPI, they reached out in October. They used some of that data that Stanford had to get some funding to bring it more local. And so in October, we sent them our first sample for sewage surveillance. In 2021, we continued that program with UIC, but we also added the Department of Health and Human Services phases. They had a phase 1 and a phase 2 program that we participated in. And then in October, we actually worked with the University of Florida down in Gainesville for a program for some opioid development and monitoring. In 2022, UIC kind of had taken that data, pushed it more to the state level, and started the Illinois Wastewater Surveillance System. And so in January, we officially transitioned from the UIC research program to their state monitoring program. In February, we started working with the CDC News program. They've had several phases and iterations during that time. And so that's where we were in 2022. In 2023, we continue these programs. We're still a participant in IWSS. CDC News program, we actually ended our participation with the end of the pandemic in May at the direction of our health department. But in May, we also picked up an antimicrobial resistance project with the University of Illinois down in Urbana-Champaign. So these are some of the bigger programs we've participated in. We've sent samples kind of one-off here and there throughout the time. We've participated in a few pilot programs that have lasted less than a month here or there, but just kind of shows you how we kind of added and brought back some programs. So how does this kind of work? What do we look like? The Metropolitan Water Reclamation District is not one treatment plant. We are 7 treatment plants that have 8 influent sources across all 7. Up in the north area, we have 4 treatment plants. To the south, we have 2 treatment plants, or Lamont and Calumet. And then in the middle and the central, we have Stickney, which is just west of Chicago near Midway Airport. one of the things I want to kind of highlight is that we have 3 laboratories at these treatment plants, one in the North area at Egan, one at Stickney, and one at Calumet. O'Brien, Stickney, and Calumet actually serve the city of Chicago as well as suburban Cook County. The population of these is over 1 million individuals for each of these treatment plants. So it's kind of a large, that's why we kind of consider them large. Egan, Curie, and Hanover Park are more of our mid-sized treatment plants, and Lamont is our smallest treatment plant. Altogether across Cook County, we cover 882 square miles, and we serve 129 communities. So a lot of municipalities are included in that. So this is an aerial view of our surveillance area. If any of you guys flew into Chicago, you might have seen something like this when you flew in. I want to highlight that our jurisdiction as a utility starts at the interceptors. We have these large interceptors that are about 10 feet wide in pipes. They're really nice, they're really big, but those are the yellow lines. And that's where we are allowed to start and actually sample from. The local sewers that are in front of the buildings and the street in front of you, in front of businesses and schools, those are the jurisdiction of the municipalities. And that can create some challenges when people come to us and ask to do sub-sewer shed sampling. Because when you want to sample a smaller, more localized area, we don't have permission to do that. You'd have to go to the municipalities to do all of that. We do have jurisdiction at these interceptors, but it is a little bit more of a challenge because not all these interceptors have accessible manholes. And so we're sitting there kind of like going back and forth and looking at where can we find something. The other challenge is a lot of these interceptors lie against busy streets and major intersections. So you can find one on a map that looks great. And then when you go there, it's in the middle of a 6-corner intersections where 3 streets intercept and there's really no downtime in traffic to sample. So that creates a little bit of a challenge for some of these projects that we've worked with. So how about our sample process? One of the things I kind of wanted to suggest or to bring up is that prior to the pandemic, all of our laboratories, I mentioned we have 3 laboratories, decided to kind of consolidate work due to the pricing of some equipment and changes in analytical monitoring for environmental samples. So we have 3 receiving labs, and they all have at least one specialty at these receiving labs. So our Egan lab in the north area, they're responsible for all our organic testing. Our Stickney lab in the central area is responsible for all our microbiology testing. And down at our Calumet lab, they do all our heavy metals testing. And that's just, one example for each of the labs. So with this setup, we have our 7 treatment plants that collect all the grab and composite samples as required per day. They get delivered by a courier to the receiving lab. Once they get into the receiving lab, any pour-offs that are needed with special, preservatives, any temperature requirements, any special bottles, it's all done at the receiving lab. They get aliquoted, they get labeled, they get LIMS numbers assigned at the receiving labs. And then the receiving labs are responsible for making sure they get distributed and transferred to any of those other labs that run those special analyses. So that's how we did it prior to the pandemic and how we had that set up for all our labs. Once we started surveillance, we decided to kind of tap into the sample process. One of the questions we asked is, do we want the treatment plants to handle it? Do we want the receiving labs to handle the samples? And we decided to kind of make it the responsibility of one lab. So we asked all our receiving labs to just pour off an aliquot for us. They transferred it to our microbiology lab located at Stickney that I supervise. From there, our staff in the micro lab actually reach out for all the metadata information from our operators. So the flow rate, precipitation, some pH information. We get all of that from our operators as the samples are kind of being collected and run around the county and driven around. We're calling the operators. Once they get to the lab, we do those final pour-offs. Some of our research partners want 3 50 ml conical tubes. Others want 2 50 ml conical tubes. Some of them want a Whirl-Pak plastic bag with magnesium chloride in it. It just kind of varies depending upon the study that we are participating in. So we want to make sure that, we get everything right as far as the pour-offs. We package them up. We make sure they're refrigerated, the ice packs are on them, the proper labels are on them, and then we get them ready for shipment. We do 2 different kinds of shipment at our treatment plant or for our program. One of them is a courier service, and one of the other option we have is a delivery to a store. So some of the questions are like, why didn't we have the receiving labs do these aliquots? Part of that is because that would add additional staff and burden. We have to make sure that our other receiving labs have the information they need for all the programs, that they know what's going on. We'd also have to have them responsible for the data entry as well as distribution. In 2020, when we started with that Stanford program and project, we were actually freezing the samples at -80°C. Our microbiology lab is the only lab that has a -80 freezer, an ultra cold freezer. So it kind of forced all the samples to come to us, which it was a little bit of a blessing in disguise. Also, some of our labs don't have access to pool cars for a courier service, and there's limited entry to our treatment plants. So FedEx does not always come and pick up our samples. So why do we choose to deliver to a store? And why did I make that specific instead of just saying using a large courier? A lot of the large shipment services here in Chicago have very specific windows for pickup. When we set up pickup for samples, we will stop by between 7 a.m. and 1 p.m., or we'll stop by between 12 p.m. and 5 p.m. So if we're running our samples all around Cook County, they're not going to be here at 7 a.m. in our lab. They're not going to be ready. Maybe we'll have them ready by 1 a.m., but they definitely won't be ready by 10 a.m. That 12 to 5 window that I mentioned is like a second window. We could likely have our samples ready to go, but because of our setup and design, all shipments have to go through our procurement department in our storeroom, and the storeroom closes their doors at 3 p.m. So I've been leaving work at 4:30 and seeing FedEx come into our plant and turn around and immediately leave because they don't have access to our facility. So to kind of overcome that burden and that challenge, we actually book a pool car or one of our company vehicles and drive it to a FedEx store. Initially, we looked at like just a FedEx drop, but a lot of the CVS, Walgreens, Ace Hardware stores where they have a FedEx drop, they do not guarantee pickup. They do not guarantee pickup for those time-sensitive samples. So it's kind of a little bit more critical for us to go to the FedEx store. We noticed early on that some of the labels on the boxes that come with some programs, if you bring it in, they automatically put up a window and say, we can't touch it, we can't handle it, we don't want anything to do with that sample, we're not trained with it, put it on that box over there in the corner, we'll make sure it goes out. And part of that is just the training requirements and what degrees they have for handling samples, which is a little bit more of a challenge for a lot of us. But that seemed to work out best for us. We do use a courier service for our IWSS samples. We realized early on that if we were going to be driving them to the FedEx store, like everybody else, that's 8.3 miles to the west of our treatment plant, whereas the lab is located 8.2 miles east. So it was either, we drive it down to we're headed about the same amount of miles to get to either place. And so we actually were able to arrange a courier service for that to make it work out. So that's kind of how we set that up. So how did bringing this burden from the operations staff, from our treatment plants, from the receiving labs actually impact the one lab where everything was kind of coordinated? So I pulled 2 pie charts from 2019 and 2022. We tapped into that sample process and workflow and moved it there. The pie charts kind of show when we had full staff. In 2020 and 2021, we were on reduced staffing. So not everybody was in full time. So as you can see in 2019, the MPDS samples or our permit plant samples took a majority of our lab's work. Our groundwater came in second, and then our waterway sampling took the next 2 highest amounts of sampling. In 2022, you can see in the blue right there on the left side of that pie chart that sewer surveillance for overall sample totals ended up becoming the majority of our program's work. And that's just collecting across, calling metadata in, freezing them, and preparing them for shipment. Our MPDS samples were reduced a little bit. Our groundwater saw a significant reduction, and our waterways ended a little bit smaller as well. In the table at the bottom, kind of see how much the numbers actually shifted. From 2019, our NPDS samples, our permit samples, we actually saw a reduction because one of our treatment in 2019 they were trying to see if they could extend the life of that cycle. So we were running additional samples for our groundwater monitoring program in 2019 was finishing up a 3 to 4 year study with the Illinois EPA to see if there were any changes to the wells around our TARP or tunnel reservoir program. And so we had a significant amount. By 2022, that program kind of ended and our sample load dropped off. Waterways, we saw a reduction because we were also doing some wet weather monitoring on our rivers during heavy rainfall. But overall, it was kind of a blessing. We knew this reduction was going to be coming in our sample sizes, and we were able to keep the same staff load that we had, keep our same staffing numbers, and be able to bring in another program that was able to fill in some of that blank areas that we had, which I think was actually a really big benefit to our lab. So thanks to everybody for including us in that. As I mentioned, communication of the program was probably the biggest driver of our success with all of these programs. At the start of our program, we created a sewage surveillance plan, a 1.5 page document that covered the title. At the beginning, we put any changes in it. We have the contact information for myself as well as the lab. And then we have this table. And this table, I think I pulled from one of the earlier versions when we were doing about 3 different projects and programs. And this plan went to operations, it went to all the receiving labs, it went to our lab, it went to anybody that had a direct day-to-day impact on the program. And so you can kind of see that it tells you what days which project needs collections and samples from, which water reclamation plants they need samples from. Are we collecting raw sewage, primary sludge, influent, effluent? Each of the receiving labs uses a little bit different nomenclature or phrases for how they call things. So we try to make that consistent in this plan, with what they call it. So that way they understand exactly what we're grabbing, which might be different than what you see in a final report or in discussions with the program side. We also let them know what volume they needed to collect it in and what type of bottle they needed. So like for project C, we were combining Stickney West Side and Southwest Side, or North and South, if you see it on a website as far as the reporting goes. We were combining that together, and it lets them know exactly what they needed to do. Overall, this actually ended up being very beneficial for everyone. Anytime there was a major change in a program, so if we ended a partnership with somebody, if we started a new project, if we changed which plants we were participating in, there were some times when we were at that early stage with UIC, we were like, hey, cases are going up. Do you want samples from everyone now? And they were like, yeah, sure, send us more. It's fine. We would revise this plan and make sure it went out for them. And anytime there was other changes to programs, a lot of times people kind of switch their providers for their kits. We would make a note in there because everybody has just a little bit different style for that. So in 3.5 years, we are currently on our 25th version of this plan, just with all the programs and changes. And so it's really critical to just emphasize the importance of proper planning, proper communication, and making sure all of that gets out there to everyone. But it's not just those who work directly with the samples day to day that need to be involved in that. You need to make sure you're aware of our programs. This requires a multi-department effort for all of this. So our monitoring and research department, we're the ones responsible for kind of the day-to-day, those sample pour-offs, all of that work. There's probably about 30 positions that are involved with that. Our maintenance and operations, when you count the number of treatment plant operators that we call for the metadata, the plant managers that we discuss and access, information from, there's about 40 of those positions. Our engineering department, where I showed those pictures of those interceptors and the manhole locations, they're the ones who really reach out to for the GIS data, the mapping and that information. Our procurement department, I mentioned early on how, we've had FedEx turned away and whatnot. We need to let them know when those samples are coming to us. One of the things we were participating in the HHS program, and one of the providers sent kits with the treatment plant that was being sampled and Stickney's address on it, which is where we were located. And they were very confused. So like, why do we have boxes for Curie here? Curie's, this is the wrong address. And so we kind of actually had to reach out and make sure they were aware anytime we were getting sample kits or programs from them. Our general administration includes our public affairs and our commissioner staff. So this is all forward-facing individuals for our utility. They're the ones who get the questions from the Q&A box off our website. They're the ones who are attending meetings and events and are asking, hey, I don't see your data on this website anymore. Why did it go away? So we need to make sure we arm them with that information, let them know what programs we changed, why we're not enrolled in a program, are we participating in this one and not that one, and making sure they are aware. So when they have that public face, they can answer those questions as clearly and completely as possible. Our human resources department, our safety department actually falls under human resources. And so we wanted to involve them. Earlier this spring, we participated in a polio pilot. And so we wanted to make sure our discussion and our communication to our staff on site was consistent with the way they message their communication. So we made sure we included them in case anything came up with concerns about that. And then finally, our finance, law, and treasury departments, we really didn't involve them too much. We probably had about 3 positions from law come through for FOIA requests. Prior to everything being public, we got a lot of questions of, are you sampling? Are you participating? And then in Chicago, we have people who I like to call hobby FOIA-ists, they just kind of like, oh, hey, I know how to submit a FOIA, I'll do it. They ask for the police department emails and, all these other things. And then all of a sudden they're, you see them on Twitter, and the next thing you know, they're in your inbox from the law department saying, hey, this person wants your data and wants to know. It's like, well, all right, here you go. Here's the days we sampled. Here's all the metadata and the flow rate and stuff. And, you follow up later and realize they posted it in a Dropbox, and you're just like, well, all that stuff's public, like over here, but okay. But that's how we kind of used our law department. So as I mentioned, there's over 117 positions. During this past 3.5 years, the monitoring and research and our maintenance operations tend to have a lot more promotions, a lot more retirements, a lot more transfers to other departments and sections. So this number is actually probably closer to 200, if not more than 200 people who we've had to communicate our sewage surveillance programs to. So it's a lot of internal communications. This excludes all our program staff that we've worked with, all the research scientists, all of the coordinators from the CDC, Stanford, UIC, DPI. There's just a lot of people that we actually have to coordinate with for all of these programs. So I just want to thank you for giving me the opportunity to talk and kind of explain our program. Give a big shout out and thank you to all our partners who have worked with us for the research as well as our internal staff. So.
Thank you so much, Kaylyn, for kicking us off in such a fabulous way. And we will do questions after all four of our speakers have had a chance to go. All right, let me pull up my next. Now it is my pleasure to introduce Reva Katz. Ms. Katz is an epidemiologist with over 40 years of experience in public health. She led the public health efforts for 45% of Alaska's population as the epidemiologist for the municipality of Anchorage, where she also designed and created Anchorage's wastewater testing and disease surveillance program. Ms. Katz has worked in various roles in public health, including as an accreditation consultant for Beverly Health, director of patient advocacy and language interpretive services at the Grady Health System, and Director of Service Excellence at Emory University Medical DeKalb, I don't know how to say that, Regional Health. Reva was educated at Georgia State University, New York University, Georgetown University, and the Hebrew University of Jerusalem. She currently resides in Alaska and enjoys the views of the Chugach Mountains. All right, Reva, take it away.
If I don't kill myself on all the lights. I entitled my presentation Alchemy. And the reason for that is just like the alchemists tried to create gold from lead, we actually created a wastewater testing program out of thin air. For you to understand what I'm referring to, I'm going to give you a little bit of information about Alaska and Anchorage, because all of you know we're up there somewhere and it's cold, and that's probably all you know about us. But if you were to get in your car and drive from the east border of Alaska to the west border, you would have driven 2,500 miles. Now that's the same as if you got in your car in Savannah, Georgia on the Atlantic Ocean and drove to Santa Barbara on the Pacific Ocean. The state of Alaska is 630,000 square miles. Okay, that is bigger than if you combine Texas, Montana, and California. We're still bigger than that. Plus the fact that where Texas has 79,000 miles of public roads, we don't have a single interstate, and we have 17,000 miles of roads. And yes, we still use dog sleds and ski mobiles to travel, and a lot of the state is inaccessible unless it freezes, which it does less and less these days. We get one shipment from Seattle weekly. On Thursdays, the plane comes with all the pharmaceuticals, medical supplies, etc., for everybody in town. If it ain't on the plane on Thursday, nobody's got it, and we're all sitting waiting till the next Thursday, hoping it'll be on that plane. That's Alaska, okay? Alaska has about 730,000 people in all those square miles. So we have the lowest density of any place I can think of. And 45% of that population lives in Anchorage, which is a small bowl surrounded by mountains and the inlet, the ocean on one side, okay? We have only 10 other cities in Anchorage, and their combined population is only about 123,000 people. So they have what are called critical access hospitals in those 10 cities, but any sort of specialized care, any ICU, neonatal, respiratory, cardiac care, etc., is only in Anchorage, where we have 800 beds, About 125 of those ICU beds, no ECMO. Patients from most of the state are flown to Anchorage if they need specialty treatment. So that's our situation. When Delta hit, I was working for the state as the COVID epidemic investigative officer. And we had to put in place and actually implement one of our apocalypse plans. You know, those plans you write for scenarios that you never dream will actually happen. Well, the scenario happened. We got a crush. We don't have surrounding states where we can send people. We don't have anybody to call if we need more help. And our hospitals were full. So we had to begin triaging people for hospital beds. And I had 3 patients die waiting for a cardiac bed in Anchorage to open. So when I was appointed epidemiologist for the borough of Anchorage, my first priority was Omicron is coming. I don't know when it'll hit Anchorage, but by God, we're not going to implement that plan ever again. So what are we going to do? We're going to use data. We're going to predict, right? We'll know, we'll have a surge, we'll call the feds, we'll get the army. We'll be ready this time. And then I got to my office, and you have to realize Anchorage had not had an epidemiologist before, okay? And there wasn't a single file, not a single piece of data, nothing. We had no information on COVID in Anchorage. All I had were hospital beds and how many COVID patients were in the hospital. And as some of you who work in public health know, that's the end result. You can't predict from that. That's already after the fact. So we had to come up with something, and I decided, well, we'll do wastewater, okay? That'll give us great information. Only I had no staff. There was just me. I had no budget. There was just my salary. I had to bring my own pens and papers from home. We had no IT other than Microsoft Word and Excel. So not even R could be downloaded, even the freebies, because the IT department wouldn't do it, okay? We had no idea, at least I had no idea, where we could test in Anchorage. Because shipping to anywhere, how would we do that? FedEx, you have to be there by 12 noon, and it's 2 days for overnight. Okay? And I had no idea what it would entail on the testing end, on the sampling end. I'm a public health person. I'm not a molecular biologist. I'm not a lab tech. I'm not a wastewater person. And we had something maybe unique to us. Maybe some of you live in that scenario too. Our governor was busy suing the federal government every chance he got to make sure that no public health initiatives were implemented in Alaska. And our mayor had actually run on a platform of no mask, no mandate, no closure, no vaccination, never, ever. COVID could be treated with ivermectin, period. So there wasn't much chance of my getting help from any of them. When I called the state for assistance in setting up a program, they said, no, not really. We're not really interested in that. On the city level, our municipal manager said, wastewater surveillance? You mean the feds are coming to surveil us? Don't you dare. Okay. So whatever we did had to be free, and it had to be under the radar, but we needed it. Luckily, the chief medical officer was on my side, Dr. Michael Sabat. He said, let's try. What do we have to lose? You know, right now we got nothing, nowhere, so we might as well go for it. Yeah, there. This is hard to read, this slide, and I apologize. I don't usually use white in a small font, but I wanted to give you an idea of the circuitous chutes and ladders route we had to take to set up our program. Okay? Without the state support, we were not eligible to apply for ELC funding, nothing. But John Pearson, from whom you heard earlier this morning, I guess had pity on us, and he got me into news without a state. So there are all these states, and then there's Anchorage. Right? We didn't have a program yet, but I was in news and credentialed to use Decipher, and I was made part of the community of participants and could learn from my peers. And I used the fact that we're part of news, we're the only city in Alaska as part of news, to try and sell my program to others. Then I sent out emails to every name I could find, every biology professor at our university, everybody who had written an article that I had read, you name it, I wrote them and said, hi, I'm the Anchorage epidemiologist. We have no money, no budget, and no governmental support. We're desperate. Can you help us set up a wastewater program? Half the people responded, and half of those helped us. Whether it was giving us information, protocols that they had used, referring us to somebody else. That's how I met Anna, got help from WEF and how to write our proposal and how to set it up, got introductions to utility people. That's how I met Dr. Brandon Briggs, who directs, I didn't even know we had a BSL level 2, biosafety level 2 lab right at our university that could do qPCR testing for us, okay? There was a lot that people came and helped us with. We were like the poor little match girl with their nose stuck against the glass, and all the people felt sorry for us, gave us information, and from that, I was able to craft a program for us. Now our program, it's no longer my program. It's now our program. Yes, the buck stops with me, but I could not do it if our wastewater utility had not come on board as a full partner. Okay? They pull our grab samples for free. While they're pulling samples for the official people, they pull for me too. And they have 2 technicians that do it, and they fight over who's going to drive our samples, because that way they can take an extra 10, 15 minutes for lunch, stop by, pick up pizza for everybody, and bring it back to the wastewater treatment center. Okay? Without Paul Smith's information, I couldn't do what I'm doing. And he does it under the radar, because you have to remember at this point, this is an unofficial program we're trying to pull together. At the university, they can't do it for free, but they do it for cost. What they pay for their supplies to run my test, if I get them the sample at 8 a.m. and we pull at 7 a.m., we run it over there, the loading dock takes it, I have my results before 2 that afternoon, and I only pay the cost of the tests. Without their information on it's funny, but for public health to use the data, it's got to be reliable and it has to be valid, okay? I can stand on my interpretation. I'll be glad to show that my interpretation of the data and what I think it means for the public health scene in Anchorage is valid and reliable. But I can't vouch for the lab sampling or the laboratory testing. I have to rely on my cohorts for that. We have to communicate. They're the ones that tell me that a glacier melted and we have this flood of wastewater coming in. They're the ones that tell me that I have to account for the 6,000 people per cruise ship, 4 of which docked yesterday, all flooding into Anchorage. Without them, I'm basically nowhere. I'm only the sort of end person that gets their valid, reliable numbers, their explanatory information, and can use that to come up with something that represents Anchorage. It turns out that at one point, Anchorage was doing wastewater testing before I got to my job. The utility had been contacted by the CDC and said, here, we have free testing, you want to join? And I said, sure. And they did it, and they did it for a few months, and they got numbers from the test, and then they said, what the heck are these numbers? And they said, we quit, because it doesn't make any sense to us. We can't use these numbers. So that's why I say without the good communication, even now, I swear to you, every 2 months I get an email from Paul at the wastewater. You still using these numbers? And I'm like, yes, this is the only data point I have. I have hospital admissions and I have wastewater. Alaska does not count cases. They do not report test positivity, and deaths are at a 6-month lag. This is all I have. Okay? That is the urgency of wastewater in communities like mine. I'll call us the forgotten stepchildren who are unable to get in the main chute, ELC funding, university official programs, and just slide through. But the way we did it and got to the point where I was able to have the mayor tell me, hey, yeah, we want this program. This is not what I thought it was by going to all the other people involved. I mean, I'm in public health, so my first reactions are to talk to hospitals, doctors, etc. We want to save the health of the community. But the physical medical health isn't the only health of the community. So I found if I talked to the business leaders and explained to them that my wastewater data could help them plan, they could now say, our community is safe. Come on down. Our community is safe. I can expand my business. I can hire employees. I'm not worried about what was coming. I'll have information to plan with. Then I got supporters. When I talked to schools, they could avoid shutdowns. They became supporters. I talked to community groups that here you're going to have information to make decisions with and not be just flying with the wind with whatever you find on Twitter. I got advocates. And then, to be honest, we had 3 cases of leprosy in Anchorage. And that scared the you-know-what out of the city government. And they came to me with, I heard you had a wastewater program. Can you test for leprosy? And then I said, no, but I can test for polio. And they went, polio? And I had to explain how Anchorage is connected to the cases in New York, London, and Jerusalem. Strong connection. And how only 1 in 200 would show up with paralysis. And you won't know till it makes the headlines. But if you fund me, we can do that. Okay? So then I got official approval and we became a program. Now, most of our testing is grab sample and run through scan wastewater, the Verily program for free. We did some with BioBot for free. We reserved the university for when I can scrounge up the $520 to get them to do a confirmation test for me or an additional test for me. But we're building, and it looks like the city will fund us. And every time I see John, I give him my speech about why cities like Anchorage, who are in states that live in the 18th century, should be allowed to apply for ELC funding. So we're fighting, we're getting there, and meanwhile, we're testing. We have data that we can turn into information that we share with anybody and everybody to let them know what's happening. So I guess my message, if there are any of you, look, I'm not Chicago, I'm not Houston, I'm not Colorado, I'm not even the University of Arizona. I'm just a little bitty program in the middle of a state that's got nothing going for it with science, except a few dedicated people willing to do this. So if we could do it, if there are any of you out there struggling to establish a program or maintain your program, honey, anybody can do it. And if you need help and ideas, let me know. Thank you.
Thank you so much, Reva. I'm sure you'll get a lot of questions. Okay, now we're going to hear from Angellica Stanley. And just a note on the correction in the printed version of the program, we mentioned that Angellica would be speaking to both Wisconsin and Minnesota. She's just going to be talking about Minnesota. In 2020, Ms. Stanley joined the Wisconsin State Laboratory of Hygiene COVID in Wastewater Project. Her team processed samples from approximately 50 wastewater treatment plants, along with a handful of dorms and other localized sites. There, she was part of a team that focused on method development as well as experimental variability. In early 2023, Ms. Stanley relocated to the Minnesota Department of Health Public Health Laboratory as the wastewater surveillance project lead, where she has been working towards improving and expanding the state's current wastewater surveillance program. She has set goals to expand the targets beyond COVID and begin pilot tests at alternative testing sites that include correctional facilities, long-term care facilities, and sovereign nations. So Angellica does not have slides. So I will turn it over to you.
Hi, everybody. My name is Angellica. Sorry, I don't have any slides, so you're just gonna have to listen to me ramble on for a little bit. Like Anna said, that I just started in Minnesota back in February of this year. And when I came on board, there was a lot of changes about to take place. So before I was there was the University of Minnesota working in partnership with the Metropolitan Council to test wastewater at 36 different wastewater treatment plants across the state for COVID. They also were doing variant testing using qPCR and variant assays where you did the individual variants. And that was all going to be ending because there was a retirement by the lead scientist. So when I came on, it was just me and my supervisor and a couple other people, including one very nice epidemiologist, and we started to implement a bunch of changes. So, sorry. Okay. So one of the first things that we did was reform our contract with the U of M in order to keep them having funding in order to keep the surveillance going so we didn't have any pauses in the data. And then we started working internally, building a team of epidemiologists and a sequencing team to start working on what team's going to do what and where the samples are going to go and what we're going to test and where we're going to direct the funding. We are currently in our lab working on bringing up additional targets as well, which we will include in the first round the flu A, B, and RSV for the respiratory panel. We did purchase new instrumentation so we could automate our processes and improve the methods at the public health lab. We are also, so we're currently right now working on validating those methods and hope to have those up by the end of this month is our goal. We are also working to redo the variant data. So like I said before, they were doing the qPCR with the individual assays. So with those ending at the U of M genomics lab because of the retirement and the cost effectiveness, we have started to work with internally with the sequencing and bioinformatics team at the public health lab to do next generation sequencing on an Illumina. And we do hope to start reporting data for the variants, at least for the metro area. Our goal is to start doing that weekly again very soon. And we also are thinking of probably doing a couple of the other major cities across the state of Minnesota to begin. This is kind of my favorite part is we've been working really hard to include more alternative testing sites. So when I came on board, I looked at the map of Minnesota and I saw it on the news site, I think first, or the CDC COVID tracker board first. But if you looked at the state of Minnesota, there was very obvious gaps in coverage. And I also noticed like a lot of those gaps were sovereign nation areas. So we, my team, which is me and one other person, working with epidemiology, has kind of worked to determine where we can help fill in some of these gaps and help some of the places that might be more at risk for different health concerns, just like the long-term care facilities and such as well. So this has been one of the biggest logistic barriers that we've had to overcome, because when you talk about doing like individual sites or sovereign nations, there's a lot of steps that have to go into that, a lot of communication, a lot of collaboration. So I'm trying to make sure that we are being completely inclusive, bringing everyone to the table, meetings and emails and visits. And one of the coolest things is that we have now been able to onboard one of the sovereign nations in Minnesota, and they are their tribe is the only one able to do that at the moment, due to them having the only joint powers agreement in the state. But I got to go to their community and meet in person with their environmental director. I got to speak at the tribal health directors meeting, and I got to go to the wastewater treatment plant. Of course, you always have to do that. And the plant manager is just wonderful human. They have a lot of little frogs living in their facility. So we got poo frogs. They're kind of cute. We think we're going to make it a mascot. But yeah, so that has been a very like time consuming and heavy process, but it's really great to like just continue that partnership with the infectious disease and tribal liaison and all of the other people that have worked really hard to get this going. And we just started getting samples 2 weeks ago. So I'm very excited about that. As far as other places that we have kind of identified that aren't getting as much coverage, and as we talk about target expansion, we're wanting to add on more hospitals, long-term care facilities. We have a couple facilities that have had really tough times through the pandemic, and we're hoping that maybe with wastewater surveillance, we can not only with the long-term care facilities that have had a lot of problems throughout COVID and keeping the disease under control. We hope that not only can we provide some surveillance data so they can ramp up and reallocate sources as needed, we also hope that eventually we might not have to do so much individual swabbing, which is really taking a toll on their staffing. Right now, there's a couple of facilities that are swabbing basically every patient every day for COVID, or as we expand, we're talking about doing the anti-drug resistant genes as well. Another area that we have identified as a place of need for wastewater surveillance are correctional facilities. There have been some bad outbreaks throughout the pandemic at the correctional facilities, and that's another place, once again, that having resource allocation and knowing when to ramp up, when maybe restrictions would need to go back in place, and as we work on target expansion to look at other disease, is going to be very beneficial, not only to the employees that are there, but the people who are incarcerated as well, to help keep them safer. Let's see. Got a little out of order, sorry. So in addition to those sites, we have also been discussing other areas of need. So that's when we have brought up different hospitals in the area. We're kind of all in that discussion phase. Like I said, there's a lot of changes that have gone on, and none of this would be possible without collaboration. And I think that's been a repeating thing across all jurisdictions is that this takes a lot of people, a lot of hands on deck, a lot of communication. And in Minnesota, we're just, doing our best to keep chugging along as we work through all of these changes and implementing the sequencing and new sites and targets. And I want to say big thank you to all of the people I've sent so many emails to and have agreed to share samples and data, and many meetings, or many emails to news and to our friends here from WEF. And yeah, I appreciate all the work and dedication that we're all doing here. And yeah, thank you so much.
Thank you so much, Angellica. Okay, and now we come to our last speaker for the first session. Let me pull up his slides. We are especially grateful that he is joining because he just completed a 60-mile bike ride for a fundraiser in the Netherlands. And so he's joining in on his Sunday afternoon after biking all that way. All right, so we are now going to hear from Gertjan Medema. So Professor Dr. Medema is principal microbiologist at KWR Water Research Institute in the Netherlands, where he is director of KWR's WHO Collaborating Center on Water Quality and Health, and advisor to the WHO and the EU on water safety. He is professor of water and health at Delft University of Technology, and his main area of expertise is detection methods, transmission, risk assessment, and epidemiology of waterborne pathogens. He is one of the leading researchers in sewage surveillance of SARS-CoV-2 and has been working on this worldwide, as I'm sure we all know. So let's give a warm welcome to Gertjan.
Well, thank you very much for this introduction. I hope you see the slides. There they
This
are.
is our first, yes. Okay, wonderful.
Okay, super. Yes, in this session on case studies, it's not easy to grab the world in a case study. So I'll do my best to showcase some examples from around the world. But also I thought it would be good to see, okay, some of at least my thoughts on where do we go from here. So next slide, please. Yeah, so this is the collaborators that I've been working on, just like the previous speaker was saying. It is a team's effort, and I think that, well, in my experience and also what I see around the world, the most successful teams are teams where that bridge, so that entail both the public health sector, that may be ideally in the lead, and the water sector, and in that combination makes it very fruitful and creates use cases where you see public health use of wastewater surveillance. Next slide, please. So this is, I'm taking you back to early 2020 when we started with our surveillance and didn't even know it would work. But this was our initial data saying, hey, there's a relation between what we see in the wastewater and what we see in the patients, in the case reports. And if you, there already, there was the first indication of an early warning. So if we go to the next slide, you see that this is how it evolved in the wastewater of Amsterdam. And yeah, basically what we saw is, like many have seen around the world, that yeah, simply because not everybody is going to the testing streets, but everybody is going to the toilet, and we are 99.99% sewered country. We could see the what is happening, what is circulating with COVID in our populations, pretty unbiased in the wastewater. So it was providing an early warning and an objective, unbiased vision on what was happening in our cities. Next slide. Yeah, so the wastewater is a national leading indicator for COVID. This is the national dashboard. We have a national surveillance done by our National Institute of Public Health and the Environment, issued by the Ministry of Health. So it is Health who is in the lead of the wastewater surveillance. But we see wastewater is there one of the leading indicators, certainly now, because people have stopped testing. So wastewater is actually the only way in which we keep an eye on what is circulating with COVID. So, and if you go to the next slide, you will see from the beginning of the pandemic, the trends on the top and hospitalizations, in the middle is the wastewater, and in the bottom you see the positive tests. And so you see how the positive tests and both hospitalizations and wastewater don't match very well, and that is particularly because you see the large Omicron wave where everybody sort of got tested. And you see very high waves that dwarfed the waves of the previous variants. But if you would look closer and you look in the wastewater and hospitalizations, you see much more variability, and also the peaks of also Omicron BA4 and 5 and later. So we feel that we see that wastewater surveillance is has been throughout the pandemic, and is certainly now an objective way to look at what is circulating in our community. And as I said, because everybody's included, and not everybody will be included in testing. Next slide, please. We saw the introduction of new variants. This is the early work with digital PCR showing the alpha variant coming in based on one of the signature mutations on the left in Amsterdam and on the right in Utrecht. And you also see that Amsterdam was a bit earlier than the national average. You see the dots in orange that are the national average from patient surveillance, and Amsterdam wastewater showed it was a bit earlier in Amsterdam than in the rest of the Netherlands. So it was also a relatively high resolution way to look at introduction of new variants. Next slide, please. Yeah, it was PCRs first, and then signature mutations, but we can sequence what is in the wastewater and find a lot more details about the different mutations. And here you see also based on these the sequencing, how the alpha came in and got out again because delta replaced it. So we see a lot in what is present in wastewater. Next slide, please. The use case of wastewater surveillance, so the public health use case was shown, for instance, in the city of Rotterdam, where we looked in different areas of the city, and there was based on the wastewater compared to the positive test, there was under testing in some city areas, and the municipal health service launched an information campaign to the city areas and also mobilized test buses. You see them here to the city area to allow for the people to get tested. Next slide, please. So looking at our experience, and I think at experience from many around the world, we see that there's has been shown clear added value for the pandemic response. I guess you've experienced them, or you will come across these examples many times today. So I won't go through them individually. But if we go to the next slide, one of what I've also seen in the international experiences, particularly in the EU, where the Netherlands is part of, so we have good contacts with people that are doing wastewater surveillance in other EU countries. It is it started sort of also in, like in the US, also in America, a bit of grassroots from the academic side and from primarily the water side. The public health side was generally way too busy with the pandemic response in the traditional sense. But a common denominator in the reactions was that health agencies were wondering why they should look in wastewater for health information. There was a lot of positive input from the water sector, but certainly now the pandemic is over. Their question is also okay, but what it is not our base job to provide public health information, and what is our role there? And of course, also a lot of academic institutions got involved with wastewater surveillance, but it's also generally not up to academic institutions to do continuous surveillance effort. So it is has been an activity that has sort of been in between the different worlds. And I think where these worlds were already closely connected, there was, I see good examples of how it was being used by the public health agencies to aid in the public health response. And because it meant that the results were communicated and also, or even the wastewater surveillance, the design of the system was sort of commissioned by the public health surveillance, and their thoughts about where the added value was for them went into the design of the surveillance program. So I think that's where these worlds met. I see good examples of the interaction, and you see that I think that CDC is also a good example of, well, should I call it early adopter, or seeing all the activities in the different states happening. I see similar things happening in Europe, and I think the beauty of the CDC response is that trying to create an umbrella over these activities and try to help to bring the information that is contained in the wastewater surveillance to public health agencies, because I think, yeah, unknown as a surveillance tool, I think it does require communication and advocacy and interaction and integration into the public health information systems to make sure that the message that is in the wastewater is also recognized in the public health community. Next slide, please. I'll only briefly touch about what next. I think consolidate, integrate, and harmonize is what I see. If you go to the next slide. This is the European countries that have been embarking on wastewater surveillance program. So they have a wastewater surveillance program now. And you see that there's challenges listed there. And that different methods, different resolution in the different countries, coming from the water side rather than the public health side, sharing of data. I think you will recognize the challenges also in the that are similar as in the US between the different states. But there's also a lot of opportunities because links have been created between the public health and the water sector that have created rapid response to new questions coming up when new variants emerged. Well, now there was EG5 and BA286, where we were curious to see if that was a rapid new introduction. We could use the wastewater and share also the information between the countries. Also, when Mpox came, we could really rapidly use the wastewater in the different countries to create situational awareness about the spread of Mpox. I think, as I said, I'm a believer in the integration of the information with the traditional health information. So maybe rather than create a separate dashboard for wastewater surveillance, try to integrate it into public health information systems so that it becomes sort of the normal thing to look at and also easy to compare the wastewater data to the other data. And harmonizing data interpretation, I think the data system from CDC, if you go to the next slide, you'll also see it, because I think it's a good example on harmonization of data interpretation. Next slide, please. So the next step is, I think, to include new targets. Next slide, please. And also there, I think CDC has come up with an approach to indicate or to select new targets for different purposes. I see similar activities in different European countries. I see also differences between different countries that are embarking on the wastewater surveillance for new targets. I think although it will the variability will help us to understand to sort of pilot one thing in one country and another thing in another country. But I also believe that there is a great merit in trying to harmonize what targets we are selecting, particularly if we're looking at in the pandemic response, because that will help us to see what is circulating in one country and may move to another country. So it would be nice if we create a way to say, okay, we not only select targets that we are mainly interested in as country, but we also use the pandemic preparedness as an argument for selecting targets. Next slide, please. I think we will have an obligation to see if we can translate what we have learned to low resource and what I call low surveillance settings, populations that are poorly surveyed. Next slide, please. Colleen Norton from UC Merced, she'll also present today. She has been working on the COVID poops, and what you see here clearly in the image is the distribution of the wastewater surveillance activities over the globe. And it would be great, and there are quite some initiatives, but it would be great if we can expand the knowledge that we have created on wastewater surveillance as a tool that is relatively low cost for population surveillance for populations that are relatively poorly surveyed traditionally. And that is true for populations within countries, some populations, but it's also true for several countries in the world. And well, the map clearly shows that. Next slide, please. We've tried to collate the data in wastewater sphere that are around there in the world. Next slide, please. And you see the same picture as you see in the COVID poops about the data availability in the world. So it is great to see that there are examples of wastewater surveillance also in unsewered settings, or where only a small part of the population is connected to sewer settings. But I think we need more examples of that to understand how we can design wastewater surveillance programs in countries where there's a large part of the population not connected to the sewers. Next slide, please. So we've tried to collate within WSphere the different use cases that we come across, and we made an effort also to get use cases from parts of the world where there was also non-sewer. So the South African example, for instance, is an example, and also the Ghana example, where part of the population, or the large part of the population, was unsewered. Next slide, please. So the last point I would want to make is that now, if with a relatively efficient and cheap tool to do population surveillance, we can also start to think about a global observatory. Next slide, please. And there have been examples for Europe, where we looked into wastewater of airports and other transport hubs, and to see if we could detect new variants coming in. If you go to the next slide, you see that, oh, and maybe hit enter. Yes, thank you. And that we saw Omicron come in a few days before it was recognized in the population. So wastewater of airports is an indicator of early introduction in the country. If you go to the next slide, you see that they have been suggested as a way to do pandemic intelligence, to see through the major transport hubs what is circulating in the world, literally through the passengers that board the airplanes and bring viruses from one side to another side. Next slide, please. There's been quite some studies conducted. Well, quite some. It's still early days in the studies that are conducted. And there are also issues with airports and certainly with aircraft surveillance. But it is a tool to look at is what is coming in. And if you go to the next slide, yes, you'll see that also not only airport and aircraft wastewater, but also city wastewater already has been and can be more used to look with metagenomic techniques at what is circulating. Here you see a global inventory of what is circulating in terms of antimicrobial resistance and also of the vertebrate viruses that are circulating in the wastewaters of the different cities. Next slide, please. So we also are, like others, are embarking on looking at transport hubs and big cities as places where you could work with an intelligent surveillance system to look at what is well entering the country, but maybe also what is coming in. So there and thereby also what is brewing in other countries and being transported from there. So with the last slide, please. The idea of a global disease surveillance and pandemic sentinel system through major transport hubs is something that we will be working on. And although I recognize there will also be many issues of data sharing and governance, and but I think the good thing is that we now have the tools and it is relatively cost effective to do this. So I think we should go for it and then see where we end up. Thank you.
Thank you again, Gertjan, for joining from across the pond. I love the idea of let's just go for it and see where we end up. So now we're just going to go for it with questions and see where we end up. We have about 15 minutes for questions. I don't think we have any questions yet on Zoom, but if you have any and you're joining us online, please go ahead and put them in the Q&A. We have someone moderating that. Thank you, Carly. Any questions here in the room? If you don't mind, just raise your hand and wait for me to bring you the microphone. Okay, I saw a hand first over there. And yeah, if you don't mind standing up and introducing yourself, Adam, thank you.
Yeah. I'm Adam Gashgari. I want to first of all thank you all for just these incredibly inspiring presentations. It's evident by the amount of people in this room today that this field has grown leaps and bounds from what it was 10 years ago. But we're not to the point where we need to be ultimately. I think over the next decade, we're going to see wastewater surveillance really become a full health approach to public health surveillance, as opposed to these one-off aspects. I don't think it shouldn't take a pandemic. It shouldn't take 150,000 overdose deaths in order for us to see the value of this and to develop these projects. So from your perspectives, in the programs you've developed and the obstacles and hurdles you've had to overcome, what do we need to do in the United States in order to have wastewater surveillance become an ongoing management strategy for the whole of public health? And then what is the role of the individuals in this room to ensure that reality? Thank you.
And can you do that all in 100 words or less? All right, we'll start with our in-person. Who wants to respond from the podium? Sure, go ahead.
Your push the button.
It should be on. If it's green, it's on. Yep. You're good. Oh, just make sure you speak into it.
I think a couple big things. It is on.
Russ, there you go. Okay.
Okay.
There you go.
Sorry. Hi. Everyone can hear me now. So to answer your question of what would need to happen in the United States in order to expand and make wastewater surveillance a permanent public health tool, I would say there would be a couple big things. Obviously, continued collaboration between state and local governments and wastewater treatment facilities. I would think maybe having some kind of regular, like mandated sampling from a wastewater treatment plants might be helpful, because I know that it has been one barrier that a lot of places have had is if they don't have like the staffing or the resources, sometimes wastewater treatment plants can't continue to sample, which could hinder your labs and your local government's abilities to get the wastewater in order to test it. Trying to think beyond that. Yeah. Do you have anything you want to add?
I think it's on. I have a bit of a different view, coming from a different background. I think we have to acknowledge the elephant in the room that is not going to go away. 47% of the population in this country is not on board with any public health initiative we come up with. If we don't find a way to include them and their communities, we cannot have a representative picture of this country. And until we do that, any data that we interpret is going to be skewed. Now, we used to have, and I'll give away my age here, we used to have a policy of taking the vaccine to the virus. And what that meant was we didn't set up centers for people to come get their shots. We went door to door and we spoke to people one-on-one, and we explained and we answered questions, and then we vaccinated. Okay. And it worked. It worked. I've worked on 3 continents for too many years, and it worked everywhere. And until somebody is willing to fund those door-to-door salespeople who can go to small wastewater plants, who can go to small health departments and talk to them one-on-one, help them think outside the box, help them understand why this is not federal surveillance of their toilet habits. This is not going to put barcodes in their arms, things like that. We're not going to get anywhere. It'll still be those of you who are already here doing your testing and going along with the program. There has to be a way to fund the outliers who live in states that we all know who they are, okay? If we don't include them, they will never include themselves. And so that's our responsibility, to figure out ways to meet them, to greet them, to include them, to help them come up with programs they can live with that will include wastewater surveillance. And that takes changes in how these programs are funded. ELC won't cut it. You leave out half the population. So there has to be a whole new paradigm shift away from the standard. We don't live in the world of SARS-1 anymore. and we can't use those methods anymore. And that's my opinion.
I would agree with that. I think that's exactly right. And from a utility perspective, I think to onboard utilities and make sure that they're participating is to help them understand what exactly it is we're doing, making sure that communication is there, the messaging is there, trying to make it easy for them, that it's, you know, it's very similar to one more permit sample. You know, eventually you're going to have to test for PFAS, and this is a lot easier than that. So, you know, go ahead and participate with this. But also just like working with them, you know, like I mentioned during my presentation, we did a polio pilot with the city of Chicago, and then it kind of expanded to the state of Illinois. And I was brought on to say, you know, tell these utilities exactly what you did, try to make it simple for them. You know, when we do research at a large utility, we try and make it useful and beneficial for the small utilities. Make it something that's applicable to all of the partners across the board, because eventually everybody will need to participate or help out with that. And I think if we keep that in mind early on and make sure that, you know, what you're doing is simple and, you know, less burden on them, you have a lot easier chance of getting more buy-in to those programs.
Yeah, thank you so much, everybody. Were there questions? There's a flurry of questions online. I know we had at least another one in the room. Let me ask one from online, and Gertjan, I might pose this one to you first. So this person's asking, does the focus on COVID exacerbate the politicization of wastewater surveillance? Would this field be better served by shifting the focus to other targets, or that just make it more difficult to obtain funding? Gertjan, I would ask, could you speak to the Netherlands and the EU perspective on that, representing the whole EU, of course?
Yeah. No, well, I think in general, it means, in the current phase of the pandemic, you see that it is only logical to now think about what else could we monitor with wastewater surveillance. So if it works for COVID, and we've seen it works for quite some other pathogens as well, I think the fact that it can work begs the question for what type of diseases or what type of information is valuable to add to what we already are looking for public health information in the population. And I think that's it's true for quite a number of enteric and respiratory pathogens and for AMR, but I think it's also true. I think there was a reference to the opioids and to illicit drugs. I think there are many situations where there's our regular information is sort of at least partially blind for what is circulating in our community. So I think COVID was the showcase of, hey, this is what can work and what has added value. So I think it would be now the time to think about where to expand it to, and well, certainly for the pathogens, it's so easy to add on additional targets because you already have the material and the tests available.
Thank you. Does anybody want to add anything in person? No? All right, wonderful. All right, and I'm going to take it to another in-person question. I think it was Andrew. Yeah, you had it. Okay. Go ahead and introduce yourself.
Yeah, hello everybody. My name's Andrew Angellica. I work for Ginkgo Bioworks. But before I worked for Ginkgo Bioworks, I ran the the England wastewater monitoring program for the UK Health Security Agency. Just to give you a size of the scale of the program, we were running 4,125 samples a week. So that was a pretty large scale program. We were very, very closely integrated into the pandemic response. And I can tell you some stories about the use cases, all of that. I don't have time to do that. But I can tell you that we actually documented not just how many tests that we saved, but what the cost of the savings to the public health authorities were of doing that. That's quite important to me. So what sticks with me, and actually why I left government, was when we did a program review at the end of it, we got back from nameless, but you would know the name. We got back a review of our program, and in the margin it said, "Why did we spend £80 million on this?" Think about that. Why did we spend £80 million on this? And I think the answer to that is that everything we talk about here, we're benchmarking against COVID. So we're benchmarking against something that was an additional expense of government. We spent £37 billion in the UK on this, right? So that was a pretty large chunk that was additional funding. And the bottom line is that although I think we were very useful and we did lots of things, we saved lives, we kept businesses open, we did all of those things, nobody could see why we should retain that funding at the end of it. And the reality from inside government is, if you spend money on something, you have to spend less money on something else. So my question really, and it's sort of a challenge to the whole community, is how do we go from being something that's nice to have to something that's must have in the public health space? And what kinds of conversations, where do we have those conversations to effectuate that change? So that's just a question for everybody, but keen to hear.
No, thank you for that question and for sharing your perspective and your experience. It's sort of along the lines of a bit of the first question, but I don't know if anybody wanted to add anything to how do we get from the nice to have to must have. Anybody?
I would just say that it's probably an additional conversation you have. Like I mentioned, like our commissioners, those are elected officials. And so those are people that not only are they front facing for our organization, but they're also the ones who can go to the state legislatures and be like, this is valuable. And I think you have to start working in your committees at the state level, your elected representatives, to make sure they make it a budget priority, make sure that they make it something that's beneficial and useful. And, they recognize that, but they won't recognize and create it unless we speak up and speak out about it. And, we can hear from community members that come and, sometimes I'll get a phone call transferred and they'll be like, I don't see the wastewater data. Where is it? And, I can send them to the IWSS website and I say, you go to this Illinois wastewater surveillance website, you can toggle there, you can zoom into the maps and see exactly where your house is to know what your sewer shed is. But then you can also not just look at the COVID data, which you're telling me you're concerned about, but you can also see the influenza and the RSV. And the person who is, responsible for that, and the person who's asking that question then is more grateful because they didn't recognize that resource was out there. And I think you really need to have either a communications campaign or a big push to make sure they're aware of those additional resources.
Yeah. Can we give our speakers all a round of applause and thank you again so much. What a great way to start our day. Okay, we are now at the first break. So those of you who are in the room, take a chance to meander past the sign-up sheets for the breakout sessions. Those of you online, you can find the breakout, the list of breakout session. I know I shared that in the email with you with the details for the Zoom call-in. So anyway, we'll reconvene at the bottom of the hour, so 10:30 local time. Thank you.